As we follow the IOM, that we have an opportunity to hear from members of the audience, the public. We're invited. This is a public session. So members of the public behind me, I'm sorry, excuse my back. I'd like you to come to a microphone. You can use this one. Identify yourself and your organization, and we're going to try to limit your remarks to 3 minutes if we possibly can. So floor is open. Anyone, any of you like to speak? Yes.
Yes.
Hi, Ben.
Hi. I think
the
public seems to be an N of one, from what I can tell, from the last time and this time. And I've come again. I'm grateful for the opportunity to be here today and also at the first meeting with this high-level members of the panel and the speakers. So I thank you for that opportunity. And what led me here the first time had to do with seeing whether or not this translation of the military trauma care into the civilian community included psychological care, and I learned that that's beyond the parameters of the task, but I also learned that the conversation wasn't closed from Dr. Berwick. I'm not sure quite yet where else it can go, but I've come today to learn about that, and there were several of you here the first meeting who shared that interest, so I'm interested in anything that may have come up in the way of conversation since then. And I've also been directed today to Dr. Erdman, who will help me pursue this a bit further. But that's my primary question, but I also was interested today in hearing more about some of the surgical presentations. I'm a clinical social worker, so it's far beyond my domain, but I have had occasion to hear Dr. Schwab speak, and what has led me to have this interest is my work, as I mentioned, the first meeting with women who've lost children to violence in the streets of Philadelphia, and what I've come to call the undeclared war on the streets. So the war element is what we have in common, but the way in which the war is occurring is quite different. And I was interested in hearing about some of the surgical and medical interventions and wondering if what from any of that could apply to community violence, which would be different from shootings, mass shootings, or police shootings. These are the shootings that occur every day on many streets in this country.
Ms. Davis, would you make a recommendation to us? What do you hope that we'll take from your concerns about, especially the first point about the...
My hope is that from what I know about the VA model and my limited exposure to that was, I have some familiarity with Coatesville VA and outside of Philadelphia, but the VA model as the gold standard for trauma treatment. And what I have come to see and have attended some of the Institute of Medicine workshops, and the one in December that was focused on means of transmission, that untreated trauma is a means of violence transmission. And I think that's something that the VA has known because it's built hospitals to take care of veterans coming back from war because they're at risk for going on shooting sprees. And that's my specific interest, is whether or not there could be a mechanism put in place to put the VA model in these communities that have been permeated by violence that continues every day because of the trauma that's gone untreated, for those who survive, for the youth who are exposed to it daily. So that's my specific interest and recommendation, is that the VA model be developed and put into these communities so that those living in undeclared war zones could have the protection that's given to veterans that come back from war until they're safe to go back out into the community, but this would be within the community itself.
Any questions for Ms. Davis? Thank you very much.
Okay.
Are there any other members of the public that want to make comments? Well, thank you. Ms. Davis, just so you know, your remarks are recorded and they will be available to the public. That's part of the procedure, and I hope that's okay with you. Thank you. Great. Well, thanks. We saved a little bit of time here since we didn't have multiple members of the public want to speak. Did John leave? Did he leave in protest? John, you're still here. So you guys got cut off in a session. I did that, not Bill. Can you want to go rewind a bit, and we can spend a couple more minutes on your points, and then we'll adjourn.
Some of the last members are still with us. In medical training and teaching, the world of simulation has gotten fairly sophisticated, both for skills training and team training and education, just-in-time learning, decision-making with immediate feedback, and working in different environments. And I wanted to ask the experts, how much in the future do you think you can depend on the evolving simulation techniques to be a part of your readiness campaign?
So I'll speak first. So as far as simulation, we look at human cadavers or simulators and live tissue and synthetics with task trainers and full human patient simulators. So as a whole, they're very important. I mean, right now we weren't using the atom courses historically, at least in the training program I had. There was an anatomy class that was about an hour long, and then there was a live tissue training. But we now have a full 8-hour American College of Surgeons asset course every month. And we've worked with Dr. Boyer, and we've added on military modules for the canthotomies, burr hole craniotomies. And then in addition, we do our extremity war surgery course that we do. That all of our surgeons have to know, even though they're not neuro, opto, or ortho. And we started to do the official ATOM course on top of our regular live tissue training that we already do. As far as the synthetic simulators, we use the task trainers. They're very important, especially as we have people that don't have that hands-on experience. And it's also a good tool to integrate the team when we have the surgeons and nurses teaching their own people that under us as more as facilitators instead of instructors. One of the problems that we've come across with the potential risk of losing the live tissue training is that there is no surgical substitute right now, and there's no continuum of care. So the main products out there by Laerdal and CEA and Gamard are good at doing the ER, the initial ATLS evaluation, and you can do some ICU training on them if you want. They're very advanced for those things. You can't move them into the operating room. You can do some procedures, and the procedures on them are kind of hokey. And so there's nothing for open surgery that's out there, and most of the surgery trainers we do have on the market are laparoscopy, they're not open. And there's nothing that can move through the whole continuum of care. And we spoke to industry at the IMSH and MSHRS and the SOMA and other conferences that are out there. So hopefully they'll come up with something, because we think it's very important to integrate it. At the Role 2 surgery level, it's very important, and Dr. Mabry can speak to this for our EMT, our primary providers, and paramedics and flight paramedics too. So.
Including team training.
Well, I think it's very important for team training. We don't use it as a single modality. We use it to make sure that everyone understands their team concepts, because not only, like we said, they have to know their clinical skills as an individual, but then they have to know how to work together. It's like any other professional team. The story we tell is the Super Bowl champions are going to work better than the 2 conference teams that are at the Pro Bowl a few weeks later, because you have the best of the Pro Bowl, but you have a team at the Super Bowl. And so that's what we try to do. And using simulation is something that we can do to help get teams to function better, so they learn policies and they get used to it. And they can also do it at the home station, because they're $60,000 to $80,000, but you don't have to come to a hospital to do that. So, right.
I think that simulation training is a very important tool for education and training, but you need to have an underlying curriculum that you're trying to teach. So we use simulation to teach teamwork. We use simulation to teach equipment familiarization. We use simulators to teach to the CPGs, so they can resuscitate a patient and follow the CPGs. And simulation is great because they can do it over and over again until they do it right. But I will tell you again, just like I tried to say when I was with the panel, is education and training only takes you so far. So you can use simulation all you want, but you still need that clinical practice, because I'll tell you, I'll save that patient 100 times on the simulator, but that real patient doesn't act like the sim. Somehow he does something funny that's totally unexpected, and you need that reality as part of it. So I think, again, simulation is an important part of education training to prepare you, but ultimately you need those real patient touches with that patient that doesn't follow the sim rules to really make you an expert and make you really competent for when you're deployed.
One other additional comment about simulation and live tissue training. The most difficult thing we ask combat medics to do is to integrate the good medicine and the good tactics and function as part of a team. That's incredibly complex, and they have to develop that through simulated casualties, working with their platoon, their SEAL squad, whoever they're working with. It has got to be part of the integrated unit movement. The casualty response, as the Rangers call it, and I think that's a great word. That's a command function. Whoever that small unit commander is, he's running that casualty. It's not the medic. You know, if I'm the SEAL platoon commander, I'll tell the medic what I want him to do, you know, and he's going to do it because the answer may be shoot back, not render care. From the standpoint of medical care, what's the toughest thing we ask combat medics to do? Surgical airways. So the best paper written on how to train people to do surgical airways was written by that distinguished gentleman against the wall over there in the uniform. I recommend everybody here take a look at that because it was done with simulation. His metric was superbly well chosen, the ability to perform a surgical airway on a cadaver. You know, the live tissue, okay, you know, simulators, okay. A cadaver is the best thing that we can use as an outcome metric for is this medic trained to do this procedure or not. He had him repeat it 5 times, which is well established in the literature. We teach medics to, in training, to make a dotted line exactly where they're going to make the incision. And that really gets their attention because if they make the dotted line in the wrong place, then his buddy realizes that he almost had a surgical incision made here or there. So a lot of training things come into it, but Bob's paper was so important because that's the toughest thing that we have to teach medics, surgical airways. He got 15 out of 15, first time success using a new instrument that we've just recommended for approval or just approved. And we have to have something that does not involve live tissue training. I think live tissue training is a valuable adjunct, but if you talk to Don Parsons, that we all work with in the TC3 committee, he's one of the members, former Special Forces medic, now the Army's Deputy Director of Combat Medic Training. He says, hey guys, we have 6,000 new medics to train a year. Live tissue training is not an option, so we have to have something that works adequately without using live tissue. So please put those into the mix and consider those.
Thank you all. Yeah.
I'm sorry, did you want to call on John for his question?
Go ahead.
Please, yeah, that's what I was going to say.
Okay. John, we're going to take we're really a little over time. If you want to slip that question in now, we still have some of the panelists here. So since
it actually was a comment. I'd just like to get into the discussion between.
Okay, and then just so we look ahead. So we have to be at the restaurant at 6:45. Short comment. So John will speak, and then I'm going to make a couple of just quick instructions about tomorrow. Then we'll adjourn. Okay, John.
I think one of the important things to get into this discussion from a education training point of view, using education lingo, is the difference between familiarity and competency. And so when we have, this panel was talking about training and education, preparing for having a military-civilian collaboration. And I'm going to go back to Alec Beakley's example of his buddy who was a shooter. That guy was very, very familiar and competent with his weapon. He wasn't familiar with his weapon, he was competent with his weapon. Familiar means I know that's a weapon and I kind of know what it's for, right? Competent means I can take it apart, put it back together blindfolded in the dark. Pretty important skill. We want your trauma surgeons, my trauma surgeons, are competent in the education lingo. They're not familiar. If we do short little episodes, you rotate people in and out, a lot of those people are just familiar, right? We want our guys going to the battlefield to be competent. And so as we work this collaboration, I think we need to keep that education language that's well described, really at the forefront of how we set up those collaborations. So we turn out competent people, not folks that are familiar. Thanks
you
for
very
the
much.
opportunity.
Bill, did you have something you want to say as well? Well, let me thank everybody. I wish all the panelists were here so I could thank them for the whole day. And these are very busy, dedicated people who gave us a lot of time and stayed on time. It was remarkable. And thank you all. And I want to commend the committee. Your ability to stick with a very intense pace and schedule and just kind of be a team is very impressive to me. And there was no grandstanding. Everybody just was with it. So that's spells success. I'm very grateful to you. Of course, it all starts. But also, so Doug and Dave and Bill and Adel, also, thank you for taking the weight off my shoulders. We'll do more of that as a committee. Just two quick things. One is for tomorrow, we also have an open session, and that is review of the cases. We have 5 cases, but we've got 4. They arrived very late. 3 of them came in the middle of the night, literally. So I haven't read them. I'm going to read them tonight after dinner, and so should you. So what I've done, the staff have been very agile. They've printed them up in case you don't want to read them virtually, but you do have an assignment tonight sometime. Read through these cases, because that is what we're going to be talking about for a while tomorrow morning. And our charge includes, we have to produce the cases and use them. That's right in the charge from our sponsors and that we book at. So I'm sorry to invade your evening, but you can watch an episode of your favorite Netflix thing after you read the paper. Now, let me just ask Autumn, do you have anything logistics you want to go over with us, or anything at all? And okay. Normally, I would take time to evaluate our process tonight about how are we doing, and I don't want to take that time now. But in the morning, we'll spend a few minutes just debriefing our process as a group. Can someone give us instruction about how to get to Restaurant Nora? Can the notebooks be left in this room?
Yes, we're going to be back in this room
Yeah.
tomorrow, so anything
But if you leave your
non-personal,
case reports in the room, I'm going to know. Yeah. Before we adjourn, we need
cases that we've received have been emailed to you, and you have printouts
you
now.
have printouts of the cases and emails of the cases. Directions to Restaurant Nora.
Christy,
It's in the folder.
the folder.
Okay. Thank you all. We're adjourned. We're supposed to be here at 6:45, half an hour. So how do we get to Restaurant Nora? What's the?